Hello, greetings from Sri Shankara Cancer Hospital and Research Center. I am Dr. Aruna. I am from the Molecular Research and Molecular Diagnostics Laboratory.
Namaste Elarigu. So I am Dr. Sandhya Appachu. I am a medical oncologist at Sri Shankara Cancer Hospital. So the relevance of this talk is to create awareness regarding certain hereditary colon cancers of what me and Dr. Aruna will be jointly talking to you about. I'm a clinician. The clinician's perspectives on when the patient comes in front of us after treatment, about how to be kept on surveillance or testing if it's a cause of hereditary inheritance or family member screening is what is relevant to us. And Dr. Aruna will tell you how in the lab, when we send the patients for such testing, she would take them with counseling regarding the testing and how she carries out the testing as well. And of course, the clinical relevance of such testing will jointly discuss with you in this talk.
Dr. Sandhya, could you tell us a little bit more specifically about this inherited or hereditary colon cancer?
So whenever we talk about reasons for any kind of cancers, in general, if any kind of cancers we are talking about, so we have something as, some cause that we detect. And there can be, after all the testing, there are causes which we do not detect at all. It can be either a sporadic or idiopathic cause for that kind of cancer, or there can be a hereditary cause for such cancers. So what do you mean by hereditary is, there can be a particular cause for that cancer where the person, the index patient or the patient who has come with that cancer is having a wrong gene in their body, which could be making them prone for such cancers. And that wrong gene would also be circulating in their family members as well. So all the more relevance that yes, it is running in the family, and we need to kind of identify if yes, the culprit is a gene, and if so gene, we need to give some measures of screening for the family members also. So in this talk where we are concentrating on colorectal cancers, the most common genetic syndromes, when we call syndromes, it is a kind of association of different kind of cancers that run in families. It need not mean that the whole set of family members have colon or rectal cancers alone. It can be different kind of cancers with the gene, because of the presence of that wrong gene, they can be susceptible to. So in this talk, what we are concentrating are on two most important hereditary syndromes. One is the Lynch syndrome and the other is the APC syndrome. So when we talk about Lynch syndrome, these are the ones which cause colorectal cancers. So we know colorectal cancer means it is the cancer of the large intestine. So whenever a patient comes to our clinic, young patient, young when we call a patient who is less than 50 years a diagnosis, okay, that is when we usually identify such patients and suggest them for a hereditary testing, irrespective of a family history or not. The second is a patient comes at any age but has a significant history of cancers in their family. So whenever we talk about family members, we grade them into first degree, second degree and third degree with respect to their generations. The first degrees are their siblings, their parents and their children, and the second degree goes, the next generation, and the third a little far away. So whenever we have a set of cancers, especially for Lynch syndrome when we are talking about, so if the first degree family relatives have colon cancers, rectal cancers, or such kind of cancers which come in this syndrome, like they could also have, females can have uterine cancers, ovarian cancers, breast cancers. They can also be stomach, pancreatic cancers and small intestinal cancers. So if they have such cancers in multiple family members, like in the first degree, if one member has such cancer, in second degree, if two family members have such cancers, and in third degree, if more than 3 family members have such cancers, then it becomes relevant to test that patient for a hereditary screening panel. The type of cancers which are associated with hereditary colorectal cancers is the APC syndrome. It is something called adenomatosis polyposis cancer. So here what happens is, sometimes it's a chance diagnosis that patient has some vague symptoms or some kind of symptoms related to the colon. They go to a gastroenterologist, they get a colonoscopy done, and when the scopist or the doctor sees the colon is studded with adenomas. So adenomas are polyps, these are mucosal projections. So any person who has more than 10 or more than 50 kind of such polyps or adenomas pre-existing is a patient who has to be screened for this APC syndrome. More so, the relevance of it is in their lifetime risk of association with cancers in the future. And this is when we need to identify such patients and then counsel them appropriately and send for those kind of testing. Yeah. So Dr. Aruna, if you can kind of enlighten the audience as to how is the test conducted and what is the type of inheritance? Why are we so bothered that we need to detect such diseases? And is it such a risky thing to be detected? So certain points that you can kind of highlight.
Sure. So this type of inheritance, like what Dr. Sandhya explained, that goes in a very typical fashion is what we call as an autosomal dominant inheritance. See, every cell has two copies of genes. One you inherit from your mother and one you inherit from your father. So just like how what Dr. Sandhya explained, it is likely that you have inherited an alteration or a faulty gene from either of the parents. So very typically your risk of inheriting the faulty gene would be 50%. So like Dr. Sandhya said, of all colon cancers, about 3 to 5% could be this following this mode of inheritance, and therefore they become hereditary colon cancers. There are some genes which are very high risk factors for this type of inheritance, meaning to say that these faulty genes are a group of 4 or 5 genes. To name a few: MSH2, MLH1, PMS2, EpCAM. These are high risk genes which carry these faulty patterns of mutations, or what we call as genetic alterations. And if you have inherited this from one of the parents, or it is likely that it even skips a generation, your parent could have been a carrier and would not have had the disease, but your second degree, that is your grandparents or your parents' siblings, may have had the gene as well as the disease. This is a pattern of inheritance that we try to track when you come, when the clinician has identified you as a high-risk member. So when you come to our lab, we do a pedigree chart of who in the family has had the disease, how many people in the lineage have had the disease and are likely carriers, and then we go on to do the testing. So the risky individuals are, as Dr. Sandhya explained, already identified in the clinic, and then they come to the laboratory for hereditary testing. So we look for these specific alterations on these specific genes, and then we decide whether this is likely to be a inherited colon cancer, or what we call for non-inherited cancers are all termed as sporadic cancers. That means the inheritance of mutations are not the reason, or they are not the reason or causes for why the cancer has come to this particular individual. So Dr. Sandhya, after having diagnosed them as hereditary or non-hereditary, do you think hereditary cancers or hereditary colon cancers specifically, do they behave differently, or are they similar to, their trajectory is similar to sporadic cancers?
So that's a good question, Dr. Aruna. So this is something that patients do ask, like what does the testing make a difference? Okay. So the testing does not make a difference in treatment except in very early stages. In early stages of colon cancer, we do a screening panel on the operated specimen called MSI testing, very technical terms, and I beg your pardon if you cannot follow this sequences. So when we identify such sequences on the tumor, there are patients who relatively do well in early stages, and we might probably not end up even giving chemotherapy. The surgery will be the only treatment. So then what makes relevance for such testing is they might be prone for other cancers. So we need to screen them for other cancers in their lifetime, and we also need to identify whether their family members at risk. So this is where we would be much keen in advising patients on testing. So moving on with the discussion. So now that we have identified and we discussed about the testing, the relevance, my question to Dr. Aruna would be like, what are the different methods of testing? She's already answered. So when we talk about a testing, or like, when we talk about a vaccine for an unseen or a unacquired disease, and you're telling that you might not get in the lifetime if you give this, and we are telling that, we're going to identify this gene and tell you whether you're at risk, most of the patients are unwelcome to such talks. They're like, we are safe not knowing it. So we need to counsel them. There are a lot of anxieties associated with the diagnosis, and then we will find the cause for cancer, and then we will tell whether your family members at risk, would they really want to go for it? Yes, it requires a lot of counseling. So there is something called pre-test and post-test counseling, which our molecular department actively engages in, and Dr. Aruna would touch upon that topic now.
Yes, absolutely. You're very right, Dr. Sandhya. The information has to be communicated to the patient very effectively. Just like you said, there are some patients who don't want to know the risk. They don't want to know what is in store. There are some patients who will say, I need to know. It's okay even if it is bad news, I just need to know. Either way, when we see the patient who has to be tested for hereditary cancer screening, then we do a pre-test counseling for all these patients. There is a genetic counselor who sits with the patient and who discusses the pedigree chart that I told you about. And then we kind of understand the psyche of the patient and explain to them that the reason that we do hereditary cancer screening is only to see if it is an inherited cancer. The reason we have to screen and test is to see if it is an inherited cancer. But a negative report does not mean that the patient will not get cancer. It only means that they are negative for inherited or hereditary cancers, and this needs to be effectively explained to the patient. Therefore, we do a pre-test counseling. Of course, we also tell them what we test on. So the preliminary diagnosis would have already been done on the tumor specimen that comes to the pathology department post-surgery. So what do we do here for inherited or hereditary cancer screening is we take a blood sample from the patient to see if every single cell in the body of the patient carries this alteration or this faulty mechanism that has been inherited from the parent or other members of the family. So the tumor has already been screened, already been tested. It's likely that the risk is high, and now we see whether it is not only specific to the tumor, but every single cell carries this alteration. Therefore, we call this as germline testing, and we collect a blood sample from the patient and we subject it to what we call as a test called next generation sequencing, where we take the blood sample from the patient, we extract the DNA, and the DNA is subjected to sequencing. So we all know that the human DNA is made up of 4 different bases, and we see for exact pattern of arrangement of these bases on the patient sample in every single cell. So we come to know whether it is a faulty gene that is present in the blood sample. That means that it is very highly likely that it is an inherited cancer. Now, the percentage of cells carrying this mutation or alteration, at what frequency is it being passed on, all of this can also be determined by the next-gen sequencing. Once we have the results of the test, we do a very in-depth analysis of what that result actually means. Does it mean that we should essentially see that this particular alteration is not present in normal population. It is present in a very small fraction of population who are all likely to be carriers of this mutation. So we do a very in-depth bioinformatic analysis on the results that are obtained from the next-gen sequencing, and then we infer or deduce what is the final report. Sometimes we end up on what we call as variants of unknown significance. So we do detect a mutation. We see that there is a certain faulty alteration in the gene arrangement, but we don't know yet what that means. it may have an implication in future where we see that there are more individuals who are carrying this mutation and a certain functional analysis has to be performed. But as of now, it will remain as what we call as a variant of unknown significance. Then we call it a VUS. If we see that this is indeed a dangerous or a faulty acquisition, then we call it a deleterious or pathogenic or likely pathogenic variant, or we call it a benign. So this is the way the reporting is done, and we come to know if this patient has actually inherited this and what is the frequency of this inheritance, and all of these parameters will be reported, and then we do a post-test counseling to the patient where we sit with the patient, we remind them what we have told them in the pre-test counseling, and we go through each and every parameter and explain to the patient what it means. If it's negative, it does not mean that the patient will never get cancer in their lifetime. It only means that they will not get this hereditary colon cancer that their father, grandfather, or the immediate family member is currently having. So this is a risk estimation for the patient as well as for other family members who seek to do this testing because the patient has come positive for the same. So after having performed this test, let's understand from Dr. Sandhya what it means clinically to the patient and what will be the next course of action. Dr. Sandhya?
So yes, as we all discussed about identifying a patient for testing, then the way in the molecular department they do the testing, they counsel and they interpret the results. Now the patient comes with the test report to our clinic again, telling yes, I've been identified to have a hereditary positive gene that has caused this cancer in me. So what do I have next? So this is of relevance to us again now that we have asked for the test. So the relevance is for the patient as well as the family members. So what do we do for the patient is like as I discussed with you earlier also, there are two different types of main hereditary syndromes that you're talking about. One is the Lynch syndrome and one is the APC syndrome. So when you talk about Lynch syndrome, we also know the set of cancers that the patient is, commonly can be prone to in their lifetime. So one, we talked about colorectal cancer. They can also be prone to uterine cancers, ovarian cancers, stomach cancers, pancreatic cancers. Okay, so this is what the whole screening is about. Trying to make them understand that what are the percentage of risks involved in the lifetime to get such cancers, not to scare them, but take the knowledge of science and be aware, and if they get any clinical symptoms to identify it quickly, or if no symptoms, get screened for detection at an early stage for such cancers. So that is one thing, that information they give of the spectrum of cancers that can be at risk too. So this is for the patient. Second is what screening measures they have to undergo. So if we talk about the Lynch syndrome, now that the patient has underwent surgery for the colon, there are two things. One, the patient has already been treated with surgery. So they can also, once we identify that there is a culprit gene and they can be prone for cancers, they can also go for a prophylactic surgery. When we call about prophylactic surgery, they are surgeries that are done before the onset of tumors in other parts of the large intestine. They can go for a prophylactic surgery of removal of the whole of the colon, that is a prophylactic colectomy. And in females, because they are at risk of uterine and ovarian cancers, they can go for removal of, especially if they completed their families, they can go for removal of the uterus and the bilateral ovaries and the fallopian tubes as well. And rest for the other cancers, like for the stomach cancer, for the pancreatic cancer, there are certain guidelines which we will tell them time to time monitoring and what type of imaging studies they have to be subjected to. In case they do not go for such prophylactic surgeries, then we need to routinely screen them for such cancers every 1 to 2 years once. Annually or 2 years once, they have to go for a colonoscopy. Colonoscopy is a method where a gastroenterologist puts the tube and visualizes the whole of the colon to identify any onset of new tumors. So this is what is required to identify such tumors in their lifetime, detect it at early, and then try to advocate surgery at a very early stage. So there are also something called chemoprevention in such cancers, especially when I'm talking about Lynch syndrome. So there has been studies of use of aspirin in these individuals, of the affected ones as well as the family members, in case we do the genetic testing and we detect that they are also at risk for such cancers, of using aspirin in their lifetime to prevent the onset of cancers. So coming to the APC, as we discussed earlier, this APC is adenomas. Adenomas are kind of mucosal projections which are the whole of your large intestine is studded with such polyps or adenomas. So in them again we advocate, especially if the patient is diagnosed, the diagnosis for the patient always carries with removal of initially the removal of that the polyp alone, and further when the endoscopy sees such thousands of polyps in the whole of the large intestine, they will essentially go for removal of the whole of the large intestine. So either they can go for a total colectomy where the whole of the large intestine is involved, then again they have additional risk of developing cancers in the rectum, which is the lowest part of the large intestine where is a storage area for our fecal matter. So if they do not want the risk for cancers for that, then they can go for something called colectomy, the total proctocolectomy, where involvement the rectum and the large intestine both are removed. But again, when they undergo total proctocolectomy, that means they will have a permanent bag where the motion gets collected there, because the collecting bag, that is the rectum, is also removed in toto to prevent risks of cancers. So when we talk about prophylactic surgeries, we have to be very clear in making them understand about the physical disabilities that they might have, or kind of this having a bag for collecting of motions and associated things that they carry, versus the risks of cancers in their lifetime and why we are advocating such surgeries for them. This was for the patient. So when we talk about the family members, we also do a mutation specific testing in them. The same kind of panel or the positive panel can be run on them. We can detect such the culprit genes that can cause cancers in them. And again, for them, what we advocate is at a very early age screening for cancers. So we take the patient, the youngest member on the family who is affected with cancers, and less than 5 years age from that youngest member will start the screening, or the screening starts as early as 30 years in Lynch syndrome and as early as 25 years in a APC syndrome. And screening necessarily means again colonoscopies. So annual colonoscopies for the APC syndrome, and once in a year or 2 years once colonoscopies for the Lynch syndrome patients. And essentially we also talk about prophylactic surgeries in them because they also hold a lifetime risk of acquiring cancers. So getting surgeries done or getting into some kind of chemo prevention, that is taking some pills to reduce the risk of cancers. So this is what it involves: diagnosing and treating the patient, then managing and screening them for cancers that they might get in their lifetime, and giving opinions on prophylactic surgeries, and family member testing and screening, and counseling of the family members for such active screening for lifetime detection of such cancers. So let's understand from Dr. Aruna how we incorporate such testing in our hospital.
So at the research laboratory of Sri Shankara Cancer Hospital, what we do, we test for both the tumor testing as well as for the risk assessment for the other family members. That means we take the blood sample from family members who are at risk, whom we identify from speaking during the pre-test counseling. We will understand who are the high-risk individuals in the family, and we request for a blood sample from these family members if they are interested to undergo the test and understand the risk. And we subject their sample to what I explained earlier, to the next-gen sequencing test using the hereditary cancer panel. So we understand what genes are carrying what type of mutations, and then we compare that result with the other family member who actually has the disease, and we determine the risk for this particular individual in their lifetime. So that is, this kind of testing is next-gen sequencing based testing using the hereditary cancer panel. We also choose, if the patient chooses to only look for that particular alteration that the parent or the grandparent had, then we can do what we call as the mutation specific testing to see if that particular mutation or genetic variation is inherited by that individual. That's also sequencing based testing that we carry out here, and that's available for all our patients and their families. The counseling is available as well. It's part of the care, clinical care. It is both the pre-test counseling as well as post-test counseling, explaining to them the pros and cons of considering the prophylactic measures. Everything will be explained to the patient. That comes as part of the clinical care, the testing as well as the counseling.
Thank you everyone, and thank you Dr. Aruna for enlightening our audience.
Thank you everyone. Thank you Dr. Sandhya. I enjoyed doing the video with you.